Good evening, everyone. Here Imran Abbas from Dubai. So again, we are live with another legend, Professor Nasser Sakran. He's well-known bariatric surgeon, and most of our bariatric surgeons know about him. In my opinion, he's one of the biggest defender of MGB, OAGB. Today, in my opinion, it is great opportunity for all of us, especially you viewers. If you have any question, any concern, you can ask question, and Professor is live with us. Sir, over to you, sir, please.
Good evening. Thank you, Imran, for the invitation. It's honest to be with you, and my honest to share our experience for all our colleagues. First of all, I am Nasser Sakran. I was born in Nazareth, in Israel. I attended medical school of Comenius University in Bratislava, Slovakia. I am a clinical assistant professor of surgery at Rappaport Faculty of Medicine, Technion, Haifa, Israel. I have postgraduate degree and medical practice in Bruges, New York, Strasbourg, Paris, and Quebec. This is our surgery. I perform bariatric surgery, all the kind of surgery. I start with, we can talk after that, but today I am one of the leader of the OAGB MGB.
Sir, there is no doubt this is reality, and I am witness in different international conferences how you defend this procedure, and especially I remember, if you remember IBC and Talia, it was amazing. I remember remarks of Haris Khaja. So after that debate, so it was really amazing. And again, we are waiting such a day. So due to COVID-19, so it was not possible. This was thinking so behind this, so we can continue our this academic activity so online, because this era is COVID era. Yes, again, so many of now organization like IFSO, IBC, Mohit, and many others, also Professor Bruno, they are doing their best. So we are also just like a student of bariatric surgery. We have started this initiative. So this interviews, this is just in light mood, and this MGB OAGB series will go till June. We have started with Robert Rutledge and will end with Professor Carbajo, and then at the end we will have some obsession, and then we will so overall conclude this. So about some, because most of these questions are repeated question, the main target is this: at the end we can conclude, yes, Professor Sakran views was this like this, Lee like this, Mario, they all are legends. So we are respect all of them. Sir, we can go ahead because there are some repeated question. So your journey of bariatric surgery.
Before I think 20 years, and in Israel, I was in one hospital in the middle of Israel, and in our hospital, we don't have the advanced laparoscopic and bariatric surgery. And I talked to the chief of the department that maybe we can try, because I like that, it's for me, it was like, science fiction to see how to do, but it's very, for me, was interesting. And the first journey for me, I was in Ghent, I think in Belgium. Oh. And I start with the AAGB, the laparoscopic adjustable gastric band. Yeah. Like every surgeon, we start with banding. And after 2-3 years in Israel, we start with sleeve gastrectomy, and the sleeve in 2004-5 in Israel. It was, wow, this is the new procedure. And after that, I said, okay, I am surgeon that I perform two kind of procedure, banding, and after that sleeve, but it's not enough. We need to, every bariatric surgeon, he need to perform all kind of operation,
Sure.
and he needs to be not only bariatric. He need to convert one procedure to another, and if have some complication, okay, this is our our Achilles, okay, that if you have some complications, you can you need to do that, something with that. And that means after that I said, okay, I will I went, I think, to again to Belgium, to Bruges this time. I meet Bruno Dillemans in 2008. It's 13 years ago. And there, really, I learned the technique, the Roux-en-Y technique, like Bruno. Okay, I came back to Israel. I performed all kind surgery in this time, and after 3-4 years of that, I see that the Roux-en-Y gastric bypass is in Israel. It's okay, but this is we had some problem. The internal hernia, marginal ulcer, the weight regain, and I said, okay, it's good operation, but it's maybe we need to search for another. All the time we talk about gold standard of the our techniques, but I think no gold standard, because every time, every year, every 2 years, we have a new procedure, and new modification. And that's the reason that I think when we was in Mon talk about no to anastomosis, only one anastomosis, less conversion, more malabsorption, more. And I said, okay, I need to do that. That's the reason that, okay. But I am the surgeon that the ego for me, it's okay, no problem. And I want to learn. And I said, before I will start that, it's for me not enough to see videos. And I talked with the Gerhard Prager.
Yeah.
In 2015, he said to me, okay, come to me. Why not? We can come to me. We can see the technique. I was there again. We talked to them. I see the technique. And from this year, we start in Israel. In Israel, in 2015, we have OAGB null, okay? And now this technique in Israel, this kind of operation now, it's 60%. It's amazing what happened today.
I know, just Nasser, if you remember this last year, IFSO registry has mentioned. Now, the most common surgery in Israel is one anastomosis gastric bypass, and also rising definite. So, when surgeons are happy and people are happy, so because one thing that already you have mentioned, and in my opinion, it is a great lesson for our youngsters, there is no ego for us. We are scientists, we are realistic. So, we love our patients, we love our practice. So when we are going to do now 60-70% our practice is going to do one anastomosis gastric bypass, definite we see something good, then we have started this procedure. Sir, if next question that is, so during this period, this 6 years, so because you have started in 2015 and now 60-70% of your practice is one anastomosis gastric bypass, have you changed any just your technique due to for your better results, like length of pouch, anastomosis, this gastrojejunostomy, side to side, end to side? I have no idea. During this period, have you changed?
First of course, I changed, because every surgeon, he need to have the standardized of the technique. Without standardizing the technique, you can have problems. The first that I changed, I can say to, I have some picture if you want after that.
Yeah, sure.
Wait.
Because why routinely I repeat this question. In my practice, earlier stages, this gastric pouch was shorter, and my patients suffer more gastric this reflux. But now, with the length, with anastomosis, as Rutledge also always mentioned, this is technical issues. If we do Technically, so this one anastomosis are MGB, then there is less chance of
Yeah.
complication. Please, sir.
First of all, you see that the position for me, the same position for all obese patients. I standing between the legs. The first assistant is in my left hand. Okay, this is my technique. The same trokers all the time. You see here. This is the camera trokers. This is for my hand. This is for my assistant. The first fire is from the right side, and after that, vertically, I from this trocar. You see here exactly. This is the pylorus. You see here clear the pylorus. This is 2-3 centimeter from pylorus. I start to have a. That means that I can have here about 18 centimeters. Okay. This is, you ask me about changing the technique. I start here a little in the angulus.
Yeah.
But now I am below the angulus, okay? And I have more than 3 to 5 centimeters. It's very important because in this side, okay, of the stomach, we have bile, okay? We live with that, okay?
Yeah.
This is
yeah.
what I change. The first fire, I said, I start from the right side, okay? And you see here, this is the first fire. Only 35 millimeters is 4.5 centimeter. You see, it's very late. The angle is very nice. Okay, I don't like, you know, this triangle. You must be very nice angle. Now I ask I make the pouch very tight. Okay, maybe Rutledge not like that. It's okay, but I think it must be tight. What's mean tight? You see that this is the gastric tube lavage. For me, I use gastric lavage tube 34 French, okay? You see the pouch tight and very, very long. Okay, you say that very well, okay? I all the time, you see, I all the time opening the GE junction. It's for me, it must be that. Because if I see some hernia, I must fix it. Okay, a little hernia, no, but sliding, you know, mid or large, I need to fix that. Okay, I open anteriorly. You see clearly that I open anteriorly, and after that, you see this is very important for all the surgeon. Don't go to this side. This is side for the spleen. You see that this is the you know that
Gastric.
yeah. I go medially. This is the last vein. What I see, I open. This is my window. Not here or not here or not here. This is the window. That's it. And now I can open it. You don't need nothing to open that. You have a little window. You see clear now. I have window. You see the spleen, and clearly you see the left cross. If I see the left cross, that means the patient they don't have internal hernia. Don't miss that. This is very important. After that, the patient they can suffer from reflux. But if you see everything that's okay, I can finish my pouch. You see clear that I have 1 centimeter from the GE junction and all okay, no problem with that. About the biliopancreatic limb. Biliopancreatic limb for me, you know, this is a big discussion for us all surgeons. Okay, to measure all the small bowel, to not measure all the small bowel, to have 150, 200, 250. Okay, I said to you something. The small bowel, okay, the small bowel, it's about 4.5 to 10 meters. 60% of our small bowel is jejunum, it's ileum, and 40% is jejunum. That means that for me, when I perform less than 2 meters, the patient, he still have 2.5 to 6 meters, okay? If you ask me when I measure all the total bowel, of course I measure sometimes, not all the time. In redo, I measure in redo all the time. But in primary, I don't do that. In patient, I don't do that because in the second hand, you see that you can have crushing of the tissue, you can have some tears, you can have leaks. and it's sometimes very difficult to measure 10 meters of small bowel. And that's the reason for me, all the patients 30 less than 35 BMI 35, it's enough for them 1.5 meter. From 35 to 45 50, but it's not good for weight loss. That is the same weight loss. You see here that I perform after 180 centimeters. I have enterotomy, and after that I have a little opening posteriorly. I think that you will have the opening for me, not anteriorly. I have posteriorly, and this is the right side. Okay, you see that this is the left side of the pouch. This is the right side. I have a little opening. Again, from the right side, my assistant, he performed the anastomosis. The anastomosis for me, it's enough. I perform 4 centimeters, but when you close, it's about 3, 2.5, 3. It's enough. You see that this is the staple line, and this is the anastomosis. Some surgeon will ask me, okay, sorry, but this side, you see this about 2-3 millimeters, they can have ischemia. But I will see why it's not have ischemia. For me, no problem with ischemia. I see you what. Before I close this window, I ask the anesthesiologist to insert you see here, the gastric lavage. Okay, this is the afferent loop, and this is the efferent loop. Okay, you see that the gastric lavage in the efferent loop now, and this is a little window. This is window. I close it manually, and I use only, my friend, I use only one suture. It's
one layer.
It's VLOC 30. I start from the left side, and I go all the time seromuscular. And you see that we took that here, the MECAB had ischemia, but if I take seromuscular from the stomach and seromuscular, I invert all the staple line. For me, ischemia, not matter. You see here, the second, you see that I see seromuscular, okay, and I close it very nice. After that, I don't finish my operation. When I close the defect, I fixed, okay, the bypass stomach with the efferent loop, and I put between the omentum, because I don't want maybe, gastrointro fistula or something like that. I fixed the limb. You see, I put the omentum in between. I close also the omentum, and you see very nice that no twisting of the efferent loop. And after I finished here, I perform, you see very nice here, I perform a blue test. And you see, if you see very clearly, when we talk about the patch, you see the diameter of the patch, and you can see the diameter of the small bowel. You see that small bowel, the diameter small bowel, it's bigger the diameter of the pouch. What it mean for me? The pouch, it can be, it's very tight and very nice. The second, if the patient have reflux, it can't have reflux because the biggest diameter is in the efferent loop, not in this pouch. After I finished that, I fixed the afferent loop, but it's not for me, our friend Karbach, we talk about
anti-reflux.
Yeah, but okay, for me, my friend, for me, first of all, this is the point, this is here the tension. Here we have a biggest tension here. For me, when I fixed from here, from the afferent loop to the side as less tension. Second, okay, the second that if you eat something, the food that can't go back to the afferent lobe, he will go to the efferent lobe. When I finished, I covered everything, and this is the step by step. After that, if you want, I can show you some videos if you want.
Sir, we will go ahead, definite, and also we will see. So just now, so Professor Mark from Belgium conveys regards to you because he's watching us online on Facebook. So Nasser, you can stop sharing here. Yes. Excellent. Really, it was excellent, and there was some technical points that already you have mentioned about your pouch, about especially the length of pouch that already you have increased. That was a good point, and also anastomosis that is posterior to stapler line and side to side, and as well as diameter. And one thing that you have added, that was the momentum between this area, so that to control, so maybe any fistula. Have you experienced any fistula before doing this, or
No,
no, just you
no,
put this?
no. I had fistula in Roux-en-Y gastric bypass. I think 2 cases. From this time when I perform Roux-en-Y or one anastomosis, also I put the momentum between the pouch and remnant stomach. Okay, I try to put it, maybe some micro leaks or something like that. And after 1 year, 2 years, 3 years, you can have say fistula. I want to prevent that.
Okay, but personally, you have never
No,
experienced this fistula.
no,
Okay, sir.
no.
But there is, so you know better than me. So in many international conferences, so the main concern, and still the concern, and also you remember, Di Maria also highlighted this one. So this GERD after MGB or OAGB and marginal ulcer. So GERD, this is a vast definition, but so this reflux, that is the bile reflux, as well as this now this marginal ulcer. So now you can see is now, I don't ask 10 years ago, 5 years ago, but in 2021, is this real concern now after all of these technique changes?
Okay, my friend. Roux-en-Y gastric bypass, or one anastomosis gastric bypass, they have the same number of marginal ulcer. Okay, this is the truth. Okay, about the marginal ulcer. The marginal ulcer in the anastomosis, it's maybe because the ischemia there, maybe micro leaks, and maybe because the smoke is we see more in smokers or patients that use NSAIDs or something like that. Of course, today when I have my patient, they come to me in my clinic. I talk about everything. Also, I talk about the smoking. For me, it's relative contraindication today. For all gastric bypasses, for all kind of bypasses, contraindication. If the patient wants operation, first of all, my friend, you must stop smoking. Okay, about the reflux. My friend, we talk about acid reflux or bile reflux.
Yeah.
Okay, we know that the band and the sleeve, they are the most GERD is there because the acid reflux is the problem. The acid reflux we can have after we can have Barrett and esophagitis, and maybe we have some publication. It's rare, but we have some publication about malignancy there. When we talk about bile reflux, I say again, if you make the procedure like you see, if you have very long and tight pouch, my patient, they don't suffer from, they don't come to me. Maybe some percent of them, I don't say 100%, sorry,
Yeah.
but they don't come to me. I perform more than 5 years this kind of procedure. I don't see the patients come to me that they have bile reflux. The patient, we see some picture that they have the green tongue or some.
Yeah.
I don't see that. Okay, again, maybe we can. If you correct, if you have the diaphragmatic hernia, hiatal hernia, if you make the pouch very not tight and very, very long, I think you can't see this kind of problems, of complications. And for me, if you ask about contraindication, when I perform Roux-en-Y, I don't perform one anastomosis. I perform one anastomosis for all patients, but for some patients, I don't perform. For who? For patients that have Barrett, for patients that have esophagitis, grade C and D. Okay, maybe I have esophagitis grade A now.
Yeah.
You know that. Okay, I talk about C and D and ESO and BARIT. Okay, and if the patient have huge, okay, huge diaphragmatic hernia, here I can talk about the Roux-en-Y. But I have another, and maybe because the smoke is we see more in smokers or patients that use NSAIDs or something like that. Of course, today when I have my patient, they come to me in my clinic. I talk about everything. Also, I talk about the smoking. For me, it's relative contraindication today for all bypasses, for all kind of bypasses, contraindication. If the patient wants operation, first of all, my friend, you must stop smoking. Okay, about the reflux. My friend, we talk about acid reflux or bile reflux.
Yeah.
Okay, we know that the band and the sleeve, they are, they are the most shared is there because the acid reflux is the problem. The acid reflux we can have after we can have Barrett and esophagitis, and maybe we have some publication. It's rare, but we have some publication about malignancy there. When we talk about bile reflux, okay, I say again, if you make the procedure like you see, if you have very long and tight pouch, my patient, they don't suffer from, they don't come to me. I don't, maybe some percent of them, I don't say 100%, sorry,
Yeah.
I am,
Yeah.
but they don't come to me. I perform more than 5 years this kind of procedure. I don't see the patients come to me that they have bile reflux. The patient, we see some picture that they have the green tongue or some.
Yeah.
I don't see that. Okay, again, maybe we can. If you make if you correct, if you have the diaphragmatic hernia, hiatal hernia, if you make the pouch very not tight and very, very long, I think you can't see this kind of problems of complications. And for me, if you ask about contraindication, when I perform Roux-en-Y, I don't perform one anastomosis. I perform an anastomosis for all patients, but for some patients, I don't perform. For who? For patients that have Barrett, for patients that have esophagitis of grade C and D. Okay, maybe I have esophagitis grade A now.
Yeah.
You know that. Okay, I talk about C and D and ESO and Barrett. Okay, and if the patient have huge, okay, huge diaphragmatic hernia, here I can talk about the Roux-en-Y. But I have another contraindication for Roux-en-Y or for anastomosis. We know about cirrhosis,
Yeah.
Crohn's disease,
Yeah.
colitis, etc., etc.
Yeah. Sir, just because already you have mentioned in large size hiatal hernia and in GERD with esophagitis C and D, you never press. What is my question? Have you experienced OAGB with huge or large size hiatal hernia or esophagitis C and D, and after surgery that situation become worse?
Uh, okay, I say I convert some patient. I convert only my patient only for malnutrition. I have 3 patients that have malnutrition, but I convert some patient, not me, is 2 patients that after gastric band, and some this surgeon he removed the band and he leave up the band, upper the band, big
Oh,
stomach and diaphragmatic hernia, and he make very short pouch. Of course, the patient no weight loss and he only suffered from reflux.
reflux.
And this is the reason that I convert. I think this is was our fault, surgeon
Technical issue.
fault. Okay, yeah.
Technical issue. Yeah. Definite, sir. And so excellent, sir. Another question. So, in your experience, have you faced any intractable GERD, or because you have mentioned this case, other than that was standard MGB. We are talking about standard MGB, not technical issue with long pouch. So, patient after surgery with standard technique now that you have, and suffering with marginal ulcer, intractable marginal ulcer, if you have faced and never responds to conservative therapy, what you did for this case?
Yeah, I have, I think, one case, and I have from another, centers cases that come to me with intractable pain, or some patient have penetration to the pancreas, and some cases with perforation. Uh, Perforation, we know what we must do. The problem was what we can do with the marginal ulcer and intractable pain. Okay, first of all, I start to talk to them to stop smoking, to stop to take pills like NSAIDs, to take for 6 weeks minimally PPI high doses, and after that to go to another gastroscopy. If the gastroscopy, the marginal ulcer is the same, I can talk here with him. Our problem, when convert Roux-en-Y, one another to Roux-en-Y, maybe can have the same, because
This is my
yeah,
question.
my other colleague in other centers, I have one case that they go to another centers and he convert one anastomosist to Roux-en-Y. And what do you think what happened to this patient? They have a new marginal ulcer. Okay.
Yeah.
Okay. I discussed with this patient before. I said to her, okay, we do everything. You still have a ulcer. I suggest for you to convert the mini to sleeve. It's not the best option, but sleeve. I don't prepare. I sometimes after malnutrition I convert to normal anatomy. But in these cases, in intractable pain, I suggest to convert to sleeve, not to Roux-en-Y gastric bypass.
Sir, excellent idea. So that is also logical as well, because if someone is suffering with this marginal ulcer, maybe again when you will do Roux-en-Y, so again patient will suffer with this, and again there will another issue for the patient. Sir, any bitter experience after MGB or OAGB? Any early complication like bleeding? Have you faced?
Uh, I will publish, I hope, a very, very, very rare complication. One of my patient, okay, this time my patient, he don't stop smoking. He suffered from marginal ulcer, Yakuza, and 4 or 3 years after the operation, he started with diarrhea and rapid weight loss, okay, and he come with anemia, hypoalbuminemia, and we make for him upper GI tests. What we found gastrocolic fistula.
Oh.
Okay, and of course this is like emergency, because this patient, have connection between the stomach and the ass. Okay, and I perform unblock resection of all what we have there, because they have the resection, the partial resection of the colon, remnant stomach, and the anastomosis, and I reconstruct to Roux-en-Y gastric bypass and reanastomosis of the colon. This is very rare, and it may be this is the first publication, and you hear about that the first.
Yeah. Nasir, we have two questions because this is also our part of this interview. One question, I think, from Egypt, Dr. Mejda Ismail. He's asking when you do your first OGD or endoscopy post-operatively after this OAGB, and follow up till how many years this upper endoscopy, or this is your routine?
upper UGI or what?
Endoscopy, upper endoscopy after MGB.
We don't perform routinely for our patient gastroscopy after bariatric surgery. We perform only when the patient suffer from problems or some complications. I don't perform gastroscopy only when the patient have some complications.
Okay, sir. And another question also, Dr. Zulfikar, he is asking about what about doing urea breath test, rule out H. pylori? Are you rule out in routine and
For me, in when I perform gastric bypass, not sleeve I stopped with band. Okay, so I must say to you that 10 years ago I said no more band, and I stopped with band. When I perform sleeve, it's not matter for me if the patient have Helicobacter pylori positive or not, but if I perform bypasses through NY or OAGB, we perform for all our patient gastroscopy before, and with the patient have Helicobacter pylori positive, he must have eradication before the operation, and we do that. I think in all Israeli guys, we have the same system here.
excellent, sir. Sir, now over to you if you want to show any video.
Yeah.
Also, many comments regarding your technique, and they are asking so about this. This was excellent information. These are our comments from viewers.
Yeah. Thank you very much. Okay. I have a short videos for you, and also redos. I will start, if you want, I will start with primary procedure.
Excellent.
You see here, I can talk, yes. You see here exactly, I start with below to the pylorus, I go to the, not up, I go to, you see that this is about 3 centimeters from, I think, from the pylorus. And you see here that clearly that I use 4.5 centimeters stepper. This is from the right side, and that I go vertically. It's about 40 minutes procedure. That's all. If you have standardized the technique, I said to you, okay, I use sometimes echelon or I drive is no problem. Every time you see here, I open the G junction. I don't like, some surgeon, OAGB surgeon, don't touch this area. I start with Roux-en-Y gastric bypass. I know what's mean that region. I open, here you see exactly, this is the veins. I go medially to these veins, and this is my window. All the time I do that, and all the time I check if the patient have some hernia here. After that, when I do that, you say I finished my pouch, and this is the gastrotomy. It is all the time from the right side, and this is posteriorly, and this means it's end, okay? Because I put it, and after that, I measure here this patient. I have 2 meters, okay. I perform. It's for me every that is 5 centimeters and 5 centimeters. Okay, after that I perform enterotomy. It's the same. And here, here you see the clearly that I perform the gastrojejunostomy, and now again I ask the anesthetic. You see the zonda, the gastric lavage 34, and this is I used here right hand. Okay, it is very difficult, but I am surgeon that I use 2 hands. Okay, you need to have right hand because it is very nice, and you see that I convert all the staple line. For me, you see the staple line that is inverted in. Okay, and that's the reason that I said if the staple line ischemic or not ischemic for me, no, it's only I use 1 layer. I don't use never 2 layers, only 1 layer, continuous V-lock. It's very step. After that, you see here, I fix the remnant stomach, and this is the first video. The second, okay, I want, you know, a lot also in I think in Dubai or Arab countries, or they have now the most common sleeve also in the world. But we start with sleeve in 2004. Now we have a lot and a lot of redos. Okay, and this is, I will say, to why we have sometimes redos. Okay, this is my patient. This is patient that have unresected fundus and he have hiatal hernia. You see here that he have a very, it's unresected. I said that you know, some surgeon talk about dilated. Okay, it's not nice. It's not dilated. Okay, it's unresected fundus. We must sometimes be talk about that we don't do. We need to do. We need standardize the technique. We must do the best that you can. You see, this is here the short gastric untouchable. So nobody was there. And you after 1 second, you can see the huge fundus here. They leave a huge fundus. Okay, all the time when I perform sleeve or Roux-en-Y, I must clean the area of the crust, left crust. I must see that. No way that I leave that. Okay, and you said I clearly you can see here the left fundus. You see that, and now I see that this patient have a. Okay, and now I see, because I go to the left fundus, I see that the patient have also here, you can see clearly that he have diaphragmatic hernia. Okay, and you see clearly that the patient has diaphragmatic hernia. You see the big, very, very big fundus. Okay, I can't do the sleeve, and here I perform also a crurorrhaphy, and I must repair the diaphragmatic hernia. This is after redo. Sometimes it's not very nice, but here you see the hiatus and you see clearly and again I close today. Okay, before 10 years I close with Etibond. Today I use VLOC, non-absorbable. I use only one layer, 2-3 stitches, 5 minutes. I can fix that. Okay, you see that this is a non-absorbable 2-0. After that, I resizing my pouch. Okay, and you see that I must resect all this sleeve, because this is a huge sleeve. Okay, and you finally you see 3-4 centimeters of esophagus intra-abdominally, and this is what we need to do. I don't like that the attachment. I clean everything because I know I want to see the serosa. Okay, when I see the serosa, I see this. Okay, after I see the serosa from the upper side and the lower side, I can cut the tissue. And you see this also again tight and very long pouch. And after that, it is the same for me. Okay, I perform gastrojejunum, and the same stitches used from the right hand from the right to the left. Okay, this is, sorry. Okay, this is the second case that you can see. I finished the first. This is the second case, also unresected fundus. Okay, you see here. This is fundus. This is all the stomach here. Okay, you need to resize everything. You must to resect. This is the fundus, and this patient, of course, he can suffer from vomiting all the time and reflux all the time. Okay, I can move on to another video. This is patient that I had reversal, because this patient he suffered from malnutrition. And when I discussed with him about the malnutrition, that I said to him, okay, I can convert You can have the pancreatic limb 1.5 meter. You can convert to sleeve, but this kind of patient, because they have hypoalbuminemia and all the time diarrhea, they ask, please, I don't want nothing. Okay, I want, please reconstruct everything. That's all. Okay. This is again simple because you have to have again. Sorry, we go to another. This is convert to sleeve. Uh, sorry. Here, this is the anastomosis of the gastrojejunum. This is the afferent. This is the afferent. You see that this patient have some adhesions. Okay, and this is the remnant stomach. Of course, this is the anastomosis, and now he have the small bowel without anastomosis, without nothing. And after that, you need to perform gastrogastric anastomosis. Here you see here clearly the remnant stomach and the pouch. And after that, I make gastrogastric anastomosis. It's not hard, but after that the patient come again because he have weight regain. Okay, this patient he have one anastomosis gastric bypass, and this time he asked me, he agreed for sleeve gastrectomy. This is the patient after I resected the anastomosis. This is the pouch here. This is, sorry. This is the pouch. I perform again the gastrotomy from the right side, okay, and this is the remnant stomach, okay, and here you can see that anastomosis from the pouch before I perform pouch to remnant stomach, and after that I perform sleeve. You can see that. When I finished, I now ask the anesthesiologist to insert a bougie here. I use only 34, or my patient only 34 French gastric lavage tube, and now I start with sleeve, okay. But you don't forget that I have defect there. I need to close that after that, okay? And I go up, I perform the sleeve. Also, you need to resizing the pouch, okay? After I finish to resizing the pouch, I close again the defect. I use only again one layer VLOC 30 absorbable here, of course, only one layer. And after that, I ask the anesthesiologist to perform a methylene blue test. And you see that again that we perform the test, and this is the sleeve after. Okay, I am your now.
Yeah, Nasser, excellent, really. And this was, in my opinion, we have a lot of comments here, and especially Professor Mark from Belgium. So he also good comments for you.
Yeah. Hi, Mark.
And also I correct because already I have mentioned Dr. Mirza Ismail. He's from Kurdistan, Iraq, because I have asked. So he's from Egypt. Maybe it was my. So overall, Nasir, excellent. So we will go ahead because overall you have covered all the perspective of this MGB, OAGB, as well as you have covered. You have also mentioned so some this complications. So also how we deal, and one of the main issue is marginal, intractable marginal ulcer. In my opinion, this is a great message. Yes, we can change into a sleeve, because if we will change to Roux-en-Y, so again there is a chance of marginal ulcer. Then what will you do? So then we can go for sleeve gastrectomy, and that is the better chance. So just I want to ask a question. What is your opinion about truncal vagotomy?
I don't use that. Today, nobody used the truncal vacuotomy, I think.
Yeah. Because the main cause of marginal ulcer is acid production. This is mostly acid based, not bile based. Are you agree with this?
Of course, I agree that's the most common because the acid reflux, not bile reflux.
Yeah.
But but truncal vagotomy today, the patient can have suffered after that from diarrhea and after some problem, abdominal pain. I don't know what that, but I don't use that and I don't like that. Today, we surgeon, general surgeon, before 20 years, we use a lot of this kind of operation because the bleedings.
Yeah.
But today, the gastroenterologists they do everything. We don't need to do that again.
Sure, sure. This is also right. Nasir, you have mentioned in your talk so about redo surgery and BP limb in redo, and you have mentioned you bypass only to 50.
Not more. I said to you, not more, because Carpaccio, he makes 60/40.
Yeah,
We have now new publication that it's if you have more than 2.5 meters, the patient they don't have weight loss. The most weight loss it's the first two meters. After that, they can have only suffers from complications. That
will
means if the patient have failure after 2.5 meters, the problem is not the surgery. This not the surgeon this time. Okay, all the time we can surgeon say, but this time no. 2.5 meters is enough. I think we have this kind of patient. They come to us. They have diarrhea, smell not good. You need to help them. I give him creon. It's enzymes of the pancreas. Sometimes I give him something like that. But after 1 year, 2 years, all the patients start to feel better because the villi of the small bowel they now they work better maybe, and after 1 year, 2 years, all okay. And that's my message to all of us: be patient, don't hurry. Okay, some patients have diarrhea or malnutrition, we start, okay, what to do? We must do some surgery. I said no, wait, patient. First of all, after that, you can say, if you start with albumins, you start with vitamins, with everything. After that, you say, okay, I do the best that what I can. Now we have really some problem or some complication.
So Nasir, as also you mentioned this diarrhea after or steatoria after MGB. So this is routine or no? Some patients have suffering with this situation.
Okay, because I said to you, we are human. Okay, the small bowel is from 4.5 to 10 meters. Okay, sometimes I have one patient that have diarrhea, and I tailored all the small bowel. You have more than 10 meters. What happened? You don't know. Okay, sometimes, okay, some patients, they have some Crohn's or, small bowel syndrome or irritable bowel syndrome, or some patients have allergy to milk or lactose, or we don't know. After the surgery, they start with this kind of before they said to you, all okay, doctor, I have all okay, but after the surgery, they start to have this kind of complication. Of course, if the patient have Crohn's disease, you can't leave him with the Roux-en-Y gastric bypass or one anastomosis gastric bypass. You must discuss with him. Maybe to convert him again to normal anatomy or to sleep.
So Nasir, what is your routine about multivitamins after surgery? Are you prefer to give your
Of
patient
course,
for
of
long?
course. I
Yeah, to
prefer
PPI.
TPN or
No, PPI and multivitamin, both.
yeah. For me, after one anastomosis, all my patients, I suggest for him PPI for half a year, first of all. Second, all must, before we talk about multivitamins, here before the surgery, we have, I see a lot of my patients that suffer from anemia. We are in the Middle East, my friend. A lot have anemia, thalassemia. Here we have FMF here in this area, in this region, okay, and a vitamin D deficiency, vitamin B12 deficiency before the surgery, I said to you. And all these patients, I sent them before to have multivitamins. Also in Israel, the patient that have iron, okay, deficiency anemia that has 8 or 9, some, and thalassemia, we send to IV iron before the surgery. I need them to have 12 hemoglobin or 11, not less than 10, okay? And after the surgery, I suggest multivitamin for all the time for me. And I talk to them, multivitamin, it's not pills, it's good for everything. And now I am so happy that now some company here in Israel, they start, they talk with us, with surgeons and with dietitian, and we have here multivitamins for for the Middle East, because we have some multivitamins from the United States, or some my patient, they start to buy from eBay, and I talk to him, eBay or not eBay, the problem that this multivitamins when you have in some box, it's not vitamins after 1 month that you need to have in in frigid. It's I think it's not good to buy from from United States, or I don't know what. Now we have multivitamins here, and it's very good. The problem with the vitamins, you know what? The iron,
Yeah.
the taste, but yeah.
So Nasir, so regarding this PPI, how long time you prefer, for 6 months, for 3 months?
6 months,
6 months.
6 months. I said to you, when some patient are smoker, and I said to him to stop, he not stop. I ask him to have a PPI all the time.
Excellent. And also, there is a Dr. Yagnik from India. So regarding his question is, PPLM, yes, you have mentioned already, and also in Redo you have mentioned it. And yes, another question is also from viewers and as well as from our side. So this your post-op diet protocol.
Right. Okay. First of all, diet in we have here we start in Israel with the project in 2013. Okay, because I am the chairman of the society here. We start in 2013. We have 33 bariatric centers. What does mean bariatric centers? Bariatric centers must have bariatric surgeon. He must perform minimally 100 cases yearly, and he must have dietitian and must have all what he need in these centers, and he must send all the data to the Ministry of Health. Okay, that means that we have the perfect registry from 2013. About the dietitian, we can't start with a operation without the patient. He needs to meet the dietitian minimally 3 times before the operation. I take minimally once a month, not every day. Okay, we said 3 times. He go, no, it's one a month, minimally three to 6 times. He needs to go to dietitian. After the operation, we in the second day. In the second day, I don't. At the second day, I don't do nothing. No UGI, no CT, no nothing. If the patient is okay, no tachycardia, no nothing, I start with liquid In the second day postoperatively, I can discharge my patient. But before he discharge him, he meet the dietitian. Okay, we have, like protocol what every day have. It is the first month. This is the problematic month. Okay, but in our patient after OAGB or DS, they must before know that this patient they need to have something that we don't need in sleeve or band, the albumin. Okay, the albumin proteins, they need to all the time to eat proteins like like what I can do that meal, and that that vegetarian sometimes can have problems. But I think what we see after the surgery, they come to me every 3 months in the first year, and after that, the second year every 6 months, and if he need after 2 years, we stopped, but he can come to me when he wants. I see that the first 6 months that our patients sometimes can have anemia, they can have hypoalbuminemia. But after 1 year, when they come to me and we start with the dietitian, after 1 year, it's all okay. I don't know what happened to them, but maybe the dietitian changed him. Maybe the small bowel now, it's the villi there. It's better. They have better absorption. But after 1 year, all okay. That's I said to you. You must be patient. Okay. If the patient after 3 months come to you, some pain, smelling, no smelling, something like that, you can, okay, wait, it will be okay. And you know that after 1 year, it will be okay.
Nasser, really excellent, and your talk was very informative. This is really reality. So, any message for youngsters who are going to start now or in earlier stages of MGB?
I say to them, first of all, you must do the best what you can. Before you want to start with some procedure, it's not problem what kind of, you must learn the procedure before. You must go to see the procedure with 1, 2 surgeons that are are leader in this kind of procedure. After that, you can start with some assistant that can help you if you something. If you have standardized the technique, it will be the best for the patient and the best for you. It's less complication for the patient, and you can sleep home without problems.
Nasser, excellent, and really it was